Good evening, good afternoon, or good morning, depending on where you're joining us from around the world. On behalf of the International Society for Sexual Medicine, I'd like to extend a warm welcome to all of you. Today's webinar is part of the master lectures from the 2024 World Meeting on Sexual Medicine in Rio de Janeiro. Next slide, please. You have the option to add automated subtitles, including translations, by clicking on the Show Captions button, which is at the bottom of your screen, and selecting your language. Next, please. For those who may be new to our community, the ISSM is a global organization dedicated to advancing knowledge, education, and clinical care in the field of sexual medicine, keeping in mind that every human being has the right to a healthy and satisfying sexual life. Next, please. So through initiatives like this webinar series, we aim to bring together experts, practitioners, and researchers from across the globe to exchange insights and drive innovation in this important field. Next, please. These are the affiliated societies to the ISSM covering most continents. Next. And please remember our official journals, which are an excellent resource to keep up with the latest studies in sexual medicine. My name is Elisa Maseroli. I am an endocrinologist and I work at the Andrology and Gender Endocrinology Unit at Careggi University Hospital in Florence, Italy, and I am honored to serve as your moderator for this webinar. So today's session will focus on delivering cutting-edge knowledge and practical approaches to key challenges in sexual medicine, and we have three exceptional speakers who will share their expertise. Each speaker will deliver a 15-minute presentation, after which we'll open the floor for a Q&A session, and I encourage all of you to submit your questions via the Q&A button throughout the session and not through the chat. Now it is my pleasure to, next please, to introduce our first speaker, Dr. Wang. Dr. Wang is a professor of urology and director of the Sexual Medicine Fellowship Program at University of Texas MD Anderson's Cancer Center and the University of Texas Program at the University of, the Texas McGovern Medical School in Houston, Texas, and is also the president-elect of the ISSM. And now he will now share his insights on penile rehabilitation post-radical prostatectomy. Please, Dr. Wang, the floor is yours.
Now, my task today is to talk about penile rehabilitation. And first, as the president of the ISSM, I would like to welcome everyone to this webinar. Next slide, please. So this is my disclosure. Next slide, please. And I believe the penis is a gift from the gods to man, and the prostate is a gift from the gods to urologists. And I have plenty of slides today, but I'm going to try to go over and cover everything. So I'm going to go a little fast because I need to cover every slide if I can. Okay. Now the reason I talked about the prostate is a gift from gods to urologists is that everybody knows probably in this audience that the prostate cancer is the #1 cancer in America as the solid organ cancer. There has been like this for many years. And many of you may not know that in America, we perform somewhere about 90,000 radical prostatectomy, and then more than 90% are performed in these days with the robotic assisted procedure. Next slide, please. Unfortunately, based on this probably up to date, the best study available compare the open prostatectomy versus robotic assisted. The incidence of erectile dysfunction 12 months after the procedure is very similar, 75% versus 79%. And not only erectile dysfunction after radical prostatectomy, there are many life quality related issues after this procedure. However, today we can only focus on the erectile dysfunction. What is the pathophysiology after radical prostatectomy? We know that no matter how good you do the nerve sparing, many people will have neuropraxia, and also many people will have no lactational erection that will cause a hypoxia. So the neuropraxia and hypoxia will trigger apoptosis, and which will cause the smooth muscle death, and the penis will have fibrosis. That is why more than 70% of people will have erectile dysfunction. Close to 70% of the people will have a measurable loss of the penile size. and about 16% of people will have Peyronie's disease, which is a scar forming condition. Next slide, please. And if you do a study, this study was, we're done, it was, well, I was done with the courage. People get a penile biopsy before the radical prostatectomy and 2 months after the radical prostatectomy. You can see clearly there is significant loss of the smooth muscle cells with increased collagen fibers, and the erectile tissues microstructure will become disorganized. And many experts in urology, urological oncology believe that probably we have maximized our technique for nerve sparing during the radical prostatectomy, and we must establish the effective pathway to manage erectile dysfunction after the procedure. Next slide, please. Therefore, the penile rehabilitation concept was adopted more than 25 years ago. The purpose of doing this was to use drug or devices to maximize the recovery of erectile dysfunction. However, even up to date, we have not reached this goal. We will mention about this in next few minutes. And the current rehabilitation strategy we have is the PDE5 inhibitor, VED, penile injection. Occasionally, people will use MUSE, which is use the medication through the urethra. Next slide, please. Based on a recent publication, the most center participating in this study are from Europe. And the PDE5 inhibitor or the combination therapy are the most common rehabilitation strategy. And the people mostly start the rehabilitation after the catheter is removed or in 1 month. The reason of doing this penile rehabilitation early was that a study by John Moho many years ago showed that if you start rehabilitation 6 months later, the recovery of erectile function may not be as good as the people start rehabilitation earlier. However, as I mentioned earlier, even these days, we do not even know the penile rehabilitation will truly improve the erectile function. I mean about spontaneous recovery of erectile function. So keep that in your mind. Next slide, please. So this is what we're going to talk about. Is the penile rehabilitation really working? Next slide, please. Let's first talking about PDE5 inhibitor. All those 4 medication here are tested for penile rehabilitation. Next slide, please. We need to make sure that people understand that if you give the patient the PDE5 inhibitor, you must know that a patient have a functional nerve or endothelial cells to deliver nitric oxide, which will trigger the increase of cyclic GMP. Without cyclic GMP, all those PDE5 inhibitor will not work. And based on the animal study and by the nerve crush injury model, all pro-erectile function molecular or muscle or cells are improved. And if you give the PDE5 inhibitor, which in this study is a sildenafil, after the nerve crush injury, and you look at their smooth muscle content at a given point, there is obvious evidence was that PDE5 inhibitor is myogenic. In other words, compared with the sham, compared with the nerve injury, you can tell that the smooth muscle cell content is is much better than the patient within the animal had nerve crush injury. Next slide, please. The human data also support this concept. When the patient get penile biopsy right after the surgery or the 6 months after the surgery, and you check the smooth muscle cells, if the patient taking the 50 milligram sildenafil and the patient taking the 100 milligram sildenafil, there is either a maintenance of the smooth muscle cells or significant increase of smooth muscle cells. And also this famous REACT study tested the tadalafil as a rehabilitation versus on-demand usage. They did not find any benefit in terms of improvement of spontaneous recovery of erectile function. However, the benefit of preservation of penile size are obvious as shown on this slide. And we summarized the all available high-level evidence of penile rehabilitation study with PDE5 inhibitor. Unfortunately, none of the study basically showed the high-level evidence of study showed the significant improvement of spontaneous recovery of erectile function. Next slide, please. And all those study has a pretty significant limitation. For example, the most study has 1 dose of the inhibitor, and most of started with a low dosage of the medication, and the duration is not good enough. Most of the time, the study only started the patient in about 1 year, and we know that the recovery of erectile function after radical prostatectomy mostly would take 2 years and sometimes even 4 years. That is why the rehabilitation before 2022, at that time, the AUA guideline was established. So it is very clear based on the guidelines that we need to make sure the patient and physician both understand that if you use PDE5 inhibitor as the rehabilitation strategy, you need to inform that patient it may not improve their spontaneous unassisted erectile function. Next slide, please. However, we do not know this recommendation will change or not because recently there is a study published in Journal of Urology, which is a multi-center international study, including about 2,711 patients, which is a meta-analysis. Basically, what the study showed was that with moderate certainty that if the patient is taking the daily sildenafil 100 milligram, remember, daily sildenafil 100 milligram, there is a moderate certainty of confidence that the spontaneous recovery of erectile function will be better. Next slide, please. Next modality is a vacuum erector device. We know that the benefit of use of vacuum erector device is to mimic the lactational erection. You can have the patient to create an erection about 5 to 10 erection in 10 or 20 minutes. You can do this once or twice a day. The traditional misperception was that if you use a vacuum erector device, the erection obtained was the venous blood. This is not true based on the clinical study and our animal study clearly show that the vacuum erector device induced erection are mostly from the arterial blood. And this is a human penile Doppler study performed by Broderick many years ago. When you use the vacuum erector device, and you can check the cavernosal artery diameter immediately, and you check the peak systolic velocity, and obviously the VED improve the peak systolic velocity and increase the size of the cavernosal artery. Next slide, please. If you check the blood gas after the use of the vacuum erector device to create the erection, and the 72% of the blood are coming from the arterial, and the 58% of the blood coming from the arterial and 42% are from the venous. So this study clearly showed that the vacuum erector device induced the erection, mixed the blood and more with the arterial blood. So it is all the study corrected the misperception before that the vacuum device induced the erection is venous blood. However, if you do use the constrictive band applied to the base of the penis, 30 minutes, of course, the penile blood gas will become venous ischemic. Next slide, please. That is why we do not recommend people use the constrictive band for penile rehabilitation. And another study performed by Professor McConough many years ago was that he used oximeter to measure the blood gas from the corporal glands and the thigh. You can see from the slides, 6 minutes after the use of the vacuum erector device, there is still a significant increase of the oxygenation in the glands, corporal, even thigh. Next slide, please. And we recently in Madrid, we summarized all the vacuum therapy for penile rehabilitation. Again, it is the same recommendation as the PDE5 inhibitor. If you want to look at the recovery of spontaneous erectile function, you will be disappointed. However, if you look at the maintenance of the penile size, there is a strong evidence to show that with the vacuum therapy for rehabilitation, the patient penile size will be preserved. Next slide, please. What about the penile injection? This is the first modality used for the penile rehabilitation. About 90% people can achieve erection with the penile injection. Unfortunately, the dropout for this kind of modality is pretty significant. Next slide, please. We did a study a few years ago, many years ago, showed that if you ask the patient to put a patient on penile rehabilitation modalities, And about half of the patient will not use a vacuum pump 1 year later, and more than more than 2/3 of the patient will not use the injection at 8 months and 12 months. And the last thing is very disappointing was that even though the penile injection was the first modality used for penile rehabilitation, the study was very sketchy. Very few studies are available, and this study all published many years ago. And the most recent study was published in 2015, did not show any difference in terms of improvement of erectile function at 12 months and 24 months. And also, there's no any scientific or basic science study to show the mechanism of benefit of penile injection therapy. So it's very disappointing. What about the transurethral therapy, which is also called the MUSE? And we did a study many years ago, compares the PDE5 inhibitor versus MUSE, and we did not show any difference between those two modalities. That is one of the reasons MUSE are not very commonly used, and also it's kind of expensive. So very few people offer MUSE as rehabilitation these days. Next slide, please. So we talked about all those studies and why we are doing the penile rehabilitation. Based on all the publication, there is no improvement of spontaneous recovery of erectile function. Why are we still doing it? So there are signs here. Number one, based on the scientific evidence, based on the animal study, the penile rehabilitation strategy improved all pro-erection molecules in the animal model. And based on the basic science study and the clinical data, that penile rehabilitation is myogenic. In other words, improve the smooth muscle cells, which is good for the erectile function. And also based on scientific study and the clinical data that penile rehabilitation increase the tissue's oxygenation. And also based on the clinical data, the penile rehabilitation will preserve the penile size. And one thing we did not mention was that if you do penile rehabilitation, and which may improve the patient and their partner's sexual life or sexual experience, which I believe Michael might be able to chime in later in the Q&A session. And a recent study showed that if you do the penile rehabilitation, there is a possibility there might be the prevention effect to prevent the Peyronie's disease. Traditionally, the publication showed that after radical prostatectomy, the Peyronie's disease can occur in 16% of the patient. But if the patient going through the penile rehabilitation program and the incidence of Peyronie's disease is only about 2.3%, which is similar to the general population. Next slide, please. And another concern was that if you do the combination rehabilitation with a PDE5 inhibitor and a penile injection, there is a possibility to increase the chance of priapism. The John Moho study recently showed that this is not the case. The only problem is that if you use the tadalafil with a penile injection, there is a possibility to have a prolonged erection, which is defined as erection lasting for more than 2 hours. Next slide, please. And there is some new modality. Shockwave has been tested, and controversial results are seen based on this slide. I don't have time to go over. Next slide, please. And most recent study watched the patient for about 5 years, and which showed that there is a significant improvement of the patient called firm enough for firm enough erection. And if you use the shockwave, which would be better compared to the control, even the PDE5 inhibitor. And other modalities such as hyperbaric has been tested, which is showed no significant difference. The stem cell has been tested in one of the study, and 6 months there is significant improvement of the IIEF score. However, there's no data for the long-term follow-up. Next slide, please. And this is my last slides. I want my talk very quickly because we have only 15 minutes. I leave this slide for you to make a decision. I do believe we need to offer penile rehabilitation for all our patients after radical prostatectomy. Thank you so much for your attention.
Thank you, Dr. Wang. Thank you for your excellent lecture. And next, we will move on to our next speaker, which is Dr. Professor Gerald Brock, Professor Emeritus at the Western University, London, Ontario, Canada, and past president of the ISSM. And he will cover evolving approaches to optimize testosterone replacement therapy in men. Please, Dr. Brock.
Thank you very much. That was a wonderful presentation that Run shared with us. And it's great that we'll have time afterwards to have a Q&A, because I really would like to know exactly what Run is currently doing for his approach with his patients. Next slide, please. I took a slightly different view of how we should approach evolving approaches to testosterone treatment. Slide, please. Within the field of sexual medicine, I don't think any of us would disagree that the development and discovery of PDE5 inhibitors was absolutely shockingly transformatory. It changed how we treat patients. It changed how patients view sexual function and dysfunction. New slide, please. And there are some claims about the future of how we're going to care for our patients, whether it's in the Western world or other parts of the world with less advanced medical societies. Next slide, please. And the idea that some of the stuff that's out there is making these claims that are just absolutely fiction makes it very important for all of us who are on this webinar to understand that we need to use evidence. It needs to be evidence-based in terms of how we manage our patients. And probably there are very few therapeutic areas that that's more important for than testosterone treatment. There are claims about testosterone causing incredible changes to individuals. The claims in terms of muscle mass and bone density and sexual function. And I think that us as professionals in the field, we have to have the background information to really provide our patients with critical information. And that's kind of the approach I took for the 15-minute talk that I'm going to give now. Next slide, please. So I think that depending on where you are, you'll have various options for treating men who have low testosterone. I'm going to talk about how you make that diagnosis, how you decide on which particular delivery system of testosterone you're going to use. We have pills in many parts of the world. We have long-acting depots. We have injectable testosterone. We have transdermal testosterone. And all of these have various advantages and disadvantages. And I think what's important is you go through these 5 steps when you're making the management approach to a patient who is hypogonadal. First, you have to assess the patient. What are the specific ideas the patient has in terms of goals of therapy? What are they looking to treat? Is it a low sexual desire? Is it erectile dysfunction? Is it low energy or just a feeling of malaise? And I think that once you develop that part of the approach, you can then really choose which agent, which approach you want to use to really manage that patient's goals and provide them with really a therapeutic approach. With testosterone, probably more than any other agent, it's important that you monitor ongoing effects, both efficacy, but also safety. And I think that the saddest stories and the saddest patients I see are those individuals who start on therapy and then get lost to follow-up and end up with erythrocytosis or other problems from treatment that should have been managed and monitored carefully. And ultimately, step 5 is that you do have to adjust the treatment as you go forward with their care. Slide, please. It's really important you understand testosterone does have risks. And of course, many of us who've been around for a while remember testosterone was always associated with prostate cancer. And, are you going to put fuel on the fire if you give someone testosterone? I think that issue is really in the background now. And what we're thinking about more with testosterone treatment is, are you going to cause erythrocytosis? Are you going to cause an increase in red blood cell mass? And that, of course, can potentially cause cardiovascular issues. You want to make sure that you understand that patient fertility concerns, because if you give testosterone, you're giving something that's going to affect their fertility in almost all cases. For a while there was a very short-acting testosterone that we thought maybe wouldn't affect fertility, but again, that's still in development and we're still learning about the role. But certainly in a young man who's hypogonadal, you have to ask about their fertility hopes, because if you give testosterone, it's a contraceptive. You want to find out about their health situation, comorbid state. The cost is a major part of the decision-making. I work in Canada, and I can tell you that if I give parental testosterone, it's roughly 1/10 the cost of transdermal gels. And so that's something to keep in mind. You want to find out about transference. If they have a young partner, does she want to grow a mustache? One of the issues is if you give testosterone and the female partner absorbs that testosterone, there are consequences. So really informed consent for the patient, understanding their goals of treatment, understanding what the objectives and their needs are is critical to understanding how best you can manage that patient. In other words, optimizing their care. Slide, please. These are the symptoms and signs of men who have hypogonadism. And all of us can look at these and identify patients that really fit this. The problem is they are not unique to hypogonadism. You know, frailty of age can really produce many of these signs and symptoms. There's a whole host of other symptoms. Hypothyroidism can cause many of these. So really, you have to have both objective and subjective symptoms that you can identify to make that diagnosis of finding that patient really will benefit from testosterone treatment. I really liked this work that Mario and Gio did recently and published just about a year and a half ago. New slide, please. Because it really pointed out what are the critical things that men who are coming forward with low testosterone truly have an effect of therapy improving. It clearly has an effect on loss of erection, sexual desire, spontaneous erections, and frequency of sexual intercourse. It doesn't make the penis bigger. It doesn't make the erection necessarily harder. And so that's things that you need to understand. And more importantly, your patients need to understand. Slide, please. This is a really nice slide because, you know, we often think that testosterone goes down as we get older. And, you know, what happens to arterial flow within the penis? Ron talked about blood flow before and the effect of vacuum devices as well as intracavernous injection. And what this slide tells us, although it's a little bit hard to understand if you're looking at it for the first time, is that if you're older and you're hypogonadal, you're more likely to have a low cavernous artery blood flow. And this just quantifies it very nicely for you. So I would suggest that those of you who are seeing the webinar, go back, take a look at this article, because it really does, for the first time, give you a very good graphic idea of testosterone, arterial blood flow, and obviously that has an impact on erectile function. The Endocrine Society published, slide please. The Endocrine Society published a really nice report in which they really clearly identified what testosterone can do, and they're summarized here. I think that for those of you watching, really sexual drive, sexual mood, feeling of well-being, the idea that it can improve muscle mass, bone density, bone strength, but that's something that's probably going to take 12, 18, 24 months of restoring testosterone levels to really have measurable improvements in those aspects. The first thing that comes back is really improved sexual drive. Whether it improves sexual function is something that's much less common. They produced a really nice algorithm that you can use. And I think the key message here is you need to have a clinical suspicion of subjective complaints combined with biochemical evidence of hypogonadal state, whether you measure LH or measure total testosterone. And they divided it into reversible and basically non-reversible causes. For someone who has a non-reversible cause of low testosterone, then testosterone exogenous treatment should be used. Alternatively, if you can reverse it, you should try. And that would be things like health optimization, weight loss, and if they're taking drugs like opiates that can cause hypogonadism. There are a number of controversies. And in fact, if you look at various medical societies, you're going to see they have slightly different views of the world. These are evolving based on the evidence. But the big issues were, does testosterone treatment compromise cardiovascular health? And I think in 2025, we can say now the evidence is pretty clear that that's not the case. I'm going to share with you some articles that really make that case very strongly. We do know if you're hypogonadal, you are more likely to have cardiovascular events. You're more likely to have concerns with ischemia if you are hypogonadal. The risk of prostate cancer, you can see the AUA is much less concerned than the Endocrine Society because of expertise and training. And I think most of us now would say that we're not terribly concerned about increasing prostate cancer or treating men who have been treated for prostate cancer who are hypogonadal with testosterone. So these are some of the classical concerns about diabetes, cardiovascular events, prostate cancer, slide please, and also erythrocytosis. And I put the erythrocytosis there last because I think of these four issues, really the first three are non-issues any longer. I think now the evidence is pretty clear that if there isn't certainly a positive benefit of treating men who are hypogonadal in these three domains, there certainly is no evidence of causing harm. On the other hand, increased red blood cell mass is probably the biggest concern for men who are taking testosterone. particularly if it's parental. Injectable testosterone has probably a 10% increase in erythrocytosis rates that you need to monitor, need to follow, because it can cause cardiovascular events. On the other hand, transdermal and oral agents typically have lower rates of erythrocytosis. Slide, please. This was a really great group of people that were involved in this study, and I think what they looked at, slide please, is looking at the effect of testosterone on anemia. And the evidence is pretty clear that if you do have an anemic man who's hypogonadal, testosterone therapy probably can help. Slide, please. This was a beautiful study in which they looked at patients with heart failure. So they're looking at the most severely affected cardiovascular group of patients. And what they showed was testosterone in this group of patients has a number of positive benefits, both in terms of the peripheral vasculature, in terms of inflammation, in terms of muscle mass, and so on. Slide, please. And they put a number of pathways in which they gave putative pathways that the testosterone may be helpful. And at the end of the day, they all basically relied on endothelial function and muscle mass and the idea of nitric oxide mediating some of these changes as target molecules. Slide, please. The narrative was really quite cute, in which they said testosterone is like an orchid that never blooms. In other words, more information is needed until we can fully grasp the benefits of testosterone therapy. This was a project that I was involved with, published in Lancet just a couple of years ago. Slide, please. And what we found was we looked at cardiovascular events. And at the end of all of this very detailed study, we found no evidence that testosterone increased short to medium term cardiovascular risks. We didn't comment on long-term risk because the data simply wasn't powerful enough. And the studies largely didn't look at long-term outcomes. But in terms of short-term, medium-term, there's no evidence there's a cardiovascular risk. And that's what the narrative says. Slide, please. We also looked at, again, published in Lancet, what were the benefits of testosterone? Because you can't just look at side effects, you have to look at benefits. Slide, please. And what was clear from this very, very elaborate study looking at a whole group of various reported literature that were carefully analyzed is that it's clear, slide please, that testosterone therapy certainly does cause a number of positive benefits in terms of sexual functioning and quality of life. Slide please. And that in the narrative, slide please, that in the narrative section, slide please. That in the narrative section is clearly identified that there is clear evidence that in terms of sexual function, meaningful improvements in symptoms could be shown, as well as improvements in overall sexual functioning. Slide, please. So we have a bunch of studies that are out there now. This is probably the best one, the Traverse study, slide, please, in which they looked at the effects of cardiovascular risk in a patient group that are at high risk for cardiovascular events. Slide, please. And what they showed is that the testosterone level was maintained throughout the study period. Slide, please. But across a variety of different parameters and endpoints, there was no evidence of harm to the patients who were at risk for cardiovascular events who received testosterone. So it's great news. Slide, please. It tells us that some of the big things that we're worried about in a group of 5,000 patients with half receiving placebo, half getting testosterone, that there's no signal that you need to be concerned when you're seeing patients who are hypogonadal about their cardiovascular impact. Slide, please. Prostate health, what's the story with that? Slide, please. I alluded to it earlier, and I think now the sort of the pendulum is really shifting, where now we think there may be a real benefit in terms of anti-inflammatory effects and actually effect on prostate cancer. Slide, please. This was a very nice study that actually showed a significant reduction in recurrence rate of hypogonadal men who were treated with testosterone who had been treated for prostate cancer. So really the idea that we need to be worried about putting gas on a fire with giving testosterone to hypogonadal men who had prostate cancer probably is historic now. Slide, please. Abe Morgentaler really should be credited with that transformatory idea of testosterone and prostate cancer. Next slide, please. This is something that we need to think about to optimize our care. So men who are hypogonadal with a subjective and objective evidence it's a problem, you need to look at the cost, you need to look at what their hemoglobin level is at baseline, understand whether they're at risk for prostate cancer, talk about transference risk, talk about fertility, Find out if they have a history of prostate cancer, breast cancer. Find out what their preference is in terms of how you're going to deliver the drug. And find out about their history of cardiovascular disease. Slide, please. Slide, please. So again, going back to where we started, assess the patient, find out their objectives of care, talk to them about what they can afford, knowing what's available in your specific region of the world, because there's different testosterone products in different parts of the world. I can tell you that my go-to approach is typically parenteral testosterone. If men don't want to use injections, which in my world is safe and effective, then we talk about transdermal. I find that the oral therapy, by and large, don't have the same efficacy and are much more expensive for a lot of the patients. But in your part of the world, it may be different. And I think the idea of individualizing their care, optimizing their care using this pathway is very helpful. Slide, please. This was a really nice piece of work from the Italian Society Andrology, slide, please, in which they did a very detailed approach looking at the levels of testosterone, levels of LH, and looking at the calculated free testosterone level. For many of us, I think it's a little bit complicated, but they did divide it into secondary, primary, and compensated hypogonadism. So it's another approach to dealing with those patients. Slide, please. And so here you go. This is my final slide. Optimize it for the right patient, provide information, understanding the timeline of efficacy, talk about risks and benefits, but use the data, know the data, and that way you can really serve your patient best. Provide follow-up information looking at various levels of PSA, CBC, and testosterone levels on a regular basis. Thank you very much, and thank you for the invitation to participate. I look forward to some questions during the Q&A.
Thank you very much, Dr. Brock. I'm sure we will have a lot of questions that are already coming through our Q&A feature. So now we have our last speaker, which is Dr. Michal Lew-Starowicz. He's a psychiatrist, associate professor of psychiatry and head of the Department of Psychiatry at Warsaw, Poland. And we'll talk about females and then the approach to female sexual dysfunction, bridging the gap between physiology and psychology. Please, Michal.
Thank you very much. It's so challenging to talk after such a good two speakers. What I'm going to do is try to explain a little bit on the connection between the brain and the body and the perspective of medical and psychological interventions. So next slide, please. I have no conflict of interest. Next slide, please. And let me start from a brief historical introduction to better understand the whole idea of connecting mind and body, or mind and body dualism. We start from the 17th century when a famous French philosopher, René Descartes, was arguing that the natures of mind and the body are different from each other and they could exist by itself. This point of view is, even today, in many circles is hotly debated, but the views change when the science grows. And so, for instance, in the 19th century, the physiologist and philosopher Thomas Henry Huxley was perceiving consciousness as something like a steam whistle that accompanied the body, but has really no influence on how it works. So humans were more a conscious automata. One of the greatest critics of Cartesian views was philosopher from Great Britain, Gilbert Ryle. He was claiming that mind is just or the ghost is just an intelligent behavior of the body. A little bit earlier in late 19th century, Sigmund Freud, as you know, the father of psychoanalysis and the one of the grandfathers of sexology we have now, in his materialistic theory, he was asserting that mental phenomena are part and parcel of the functioning of human brain. And with that, in medicine, when psychoanalysis took over psychiatry for several decades, it was largely separated from other medical specialties and perceived clinically more as kind of psychological support. And recent advances of neuroscience make it more and more difficult to draw the line separating the neurological disorders that are perceived as structural brain disorders and psychiatric disorders that are seen more like functional brain disorders. So for the perspective of sexual medicine, structural or functional division was strongly emphasized even in the ICD-10. So you could see that sexual dysfunction, so-called no cause by organic or disorder or disease, is has been classified in the psychiatric chapter, while the so-called organic dysfunction was classified in different other chapters, such as diseases of the genitourinary system. It changed a little bit with ICD-11. Here you have more holistic view and more integrative in the chapter 17, conditions related with sexual health. We can recognize different sexual dysfunction and implement different etiological consideration that may even coexist. Next slide, please. As you all know, there was a great development of modern sexual medicine with the introduction of sildenafil in treatment of male erectile disorder, and it moved our attention much more into medical treatments, especially with attention to cardiovascular system. There was also search on the usefulness of PDE5 inhibitors in female dysfunction, so that was the first searches of so-called female Viagra, and it was found that it may improve orgasm satisfaction or sexual arousal or sexual satisfaction, but still there are not much randomized control trials to confirm that. And also there is some limited evidence that these drugs might be helpful in psychotropic medication-induced sexual dysfunction. So they may work on different levels, but still be useful for that target. Next slide, please. And the physiology of female sexual dysfunction is known to be dependent on complex biopsychosocial interplay, and it has been also subject of various integrative models, such as this circular model of sexual response by Rosemary Basson. Next slide, please. And many risk factors related to cardiovascular, metabolic, or lifestyle-related, next slide, please, or related to relationship factors, as well as perception of partner sexual function, next slide, please, and as well as existing male partner sexual dysfunction may all influence the development of female sexual dysfunction. Next slide, please. Mental health issues are very known risk factor, especially depression and anxiety spectrum disorders that are very much related with higher odds of developing desire, arousal, and orgasm dysfunction, and also sexual pain disorder that are 3 times more common when there is a premorbid depression, or even 10 times more common in women who had a history of anxiety disorder. Next slide, please. So in psychiatry, sexual dysfunction became even recognized as a part of this internalizing dimension, and there is a high degrees of coincidence between depression, anxiety disorders, and sexual dysfunction. Next slide, please. And here in the neurobiology of sexual behavior, and you can go further with the other parts of the slide, thank you. We have to disentangle 3 major issues, such as wanting, liking, and satiety. So first of all, Wanting is responsible for motivation and anticipation of sexual rewards. Through sexual incentive stimuli, it leads to liking, so to sexual arousal and to consummatory behavior, and then increasing arousal leads to orgasm, and related with orgasm, post-orgasmic satiety. All of these are related to certain behaviors. So wanting is related for seeking for sexual reward and attempts to get into sexual context, as liking or arousal is related with sexual performance, and then achieving orgasm and this post-orgasmic satiety is related rather with stopping sexual activity and not searching for more and more stimulation. All are also, of course, related with cognitive reappraisal and the perception of sexual activity, whether it is what to seek or to want it or not. So the circle of sexual response is going on. Next slide, please. On the biochemical level, there are numbers there are multiple hormones and neurotransmitters that are involved in the physiology of sexual response. And according to the dual control model, sexual dysfunction can result if there is dysfunction of excitatory or inhibitory signal by preventing adequate excitation or promoting excessive inhibition. The key players are dopamine, that is evoking attention to sexual cues and to sexual motivation, and serotonin constitute the major inhibitory neuromodulator, and it also suppresses ability for excitatory system, so mainly the dopaminergic system. And the other important players are testosterone and estrogen, which activate they both facilitate dopamine release in the nucleus accumbens, so in the brain reward system. And oxytocin and as well as melatonin are also causing increased dopaminergic stimulation in the brain. So they are also all reinforcing sexual response from desire up to arousal. Next slide, please. And together with all the neurotransmitters, you can see parallel activation or disactivation of certain brain areas. And the neuroimaging studies support deficient excitation in brains of women with, for instance, with hyperactive sexual desire disorder, where there is decreased activity in the brain regions that are responsible for sexual desire, with increased activity in these regions that are responsible more for self-focus and for moral judgment. To make this simple, orgasmic sensations, for instance, they are related to decreased prefrontal cortex activation, so decreased control, and increased subcortical activation, which is related with increased pleasure, so creating the state of cardiovascular effects related to increased sympathetic tones and all the bodily and subjective arousal and orgasmic sensation, together with sort of a carefree state of mind. Next slide, please. And as we know, emotions and cognition, they all have their neurobiological substrate. So there are some, from the neurobiological point of view, they are just activation of specialized neuronal populations with hyperactivity of the prefrontal cortex. We can expect hyposexual behavior, and with the psychological excessive behavioral suppression, what can happen is the enhanced activity within the left lateral orbitofrontal cortex, which will lead to difficulties to reach orgasm. So there is no loss of control, no carefree state of mind, has been said. Next slide, please. So, for the proper understanding of psychophysiological determinants within the dual control model is also important for the way we perceive therapeutic intervention and the targets where we search for new compounds and drugs that may be useful in treatment for such dysfunction like hypoactive sexual desire or sexual interest and arousal disorder. Next slide, please. And in fact, if you consider compounds that were perceived as possible female Viagra, some of them are already registered in some countries, some of them are used more off-label or experimentally. But they have something in common. So they mainly are thought to work through dopaminergic activation or on the level of sensitization towards sexual cues by testosterone or female hormones, or otherwise also with accompanying increase of peripheral vascular response evoking sexual arousal, especially the activation of serotonin 5-HT1A receptor in the frontal cortex region of frontal cortex in the brain may increase the dopamine release from the subcortical regions. And these are also the targets of such drugs like fludanserin or bremelanotide that works also through melatonergic system. Next slide, please. What about psychotherapies? How do they work from that angle? As we know, cognitive behavioral therapy is probably the best evidence-based in treatment of psychiatric disorders, especially we use it commonly for treatment of anxiety and depression. But it is also in clinical sexology is considered the first choice psychotherapy for female sexual dysfunction. The most of studies refer to CBT. And then it can be used in monotherapy or combined with other therapeutic approaches. So through modification of maladaptive thoughts or behavioral adaptation, exposure exercises, etc., it might parallelly lead, and it has been also evidenced in a neuroimaging study, to the decreased activation exactly in the medial prefrontal cortex and as well in anterior cingulate cortex. And it has been also related clinically with better emotional regulation and cognitive processing and motivation. Another psychotherapeutic intervention is so-called third wave therapy, mindfulness and sensate focus exercise. They are very commonly also implemented together with CBT. Mindfulness practice will consist of purposeful and conscious directing of attention to the current experience and inclusion of benevolence, compassion, and acceptance. And it is now recently gaining more and more attention and also clinical evidence as useful for the treatment of female sexual dysfunction. In the more complex treatment plans, it is commonly related with psychoeducation, combined with psychoeducation and CBT. And in neuroimaging studies, it was also found that it may lead to increased density, thickness of the prefrontal cortex gray matter and influence the amygdala activation and decrease plasma cortisol. So it also works all through the neurobiological response within the brain, of course. Next slide, please. And taking this all into account as take-home messages, we should understand that we need biopsychosocial assessment to provide really effective understanding and also the treatment of female sexual dysfunction. Next, please. And we should understand better the links between what is psychology and physiology in the determinants of sexual dysfunction in females. But it's not to choose just to decide whether we go into a medical direction or more psychological direction, and not to provide the dualistic approach, but rather to provide this complex and comprehensive treatment of sexual dysfunction, because both medication and cognitive or behavioral intervention are targeting central excitatory and inhibitory pathways, and they may improve the female sexual function if they are well implemented. So we also have to keep in mind that combined treatments, including both psychotherapy and medical treatment, might be much more efficient in treatment of female sexual dysfunction. With that said, thank you, and I'm waiting for the discussion.
Thank you. Thank you, Michal. I would like to thank all the speakers for their excellent presentations. Now we can open your lectures for the Q&A. So first, I would like to give the opportunity to Dr. Brock to ask a question to Dr. Wang.
Thank you very much. Ron, loved your presentation. Great job, as usual. Maybe just give us a quick summary of what you're currently doing for your patients.
Wonderful, Jerry. And again, I enjoy your talk as well so much, and clear up all my confusion, and that was probably one of the best testosterone summary talk. In our practice at MD Anderson, what we generally do is that when the patient had ideally, and there's some Q&A, I saw that when you start the penile rehabilitation, ideally, if it's possible, you discuss about the possible side effect of sexual function before the surgery, but that is not the case in many, many centers, because those the surgeon performing the radical prostatectomy, they don't have time, they don't want the patient to get lost, and they want to get the patient the schedule for surgical or radiation therapy as soon as they can, and they don't want to waste the time to send the patient over to you before the treatment. So generally what we do is that the patient had a radical prostatectomy, they come to our clinic as soon as possible. So how often this happens? It happens generally about in 1 or 2 months in our practice. But we informed those urological oncologists, so we want them to start the PDE5 inhibitor right after the patient gets discharged. So patient can start taking the PDE5 inhibitor, either catheter is removed or the patient can take the medication when they get home. And then patient in 1 month, because their healing is better, so we want the patient to start to use the vacuum pump. We have a detailed educational session regarding how to use a vacuum pump, when to use a vacuum pump, and how often they need to use it, things like that. And then the patient in general will be seen by me in about 2 or 3 months after they started those kind of therapy. If they are not getting any spontaneous erection or get any response, this time we will perform the penile Doppler study, and then we will have the patient start the penile injection. The penile injection in my practice is not for rehabilitation. The rehabilitation only combined with oral medication and a vacuum pump. And the injection is a provide opportunity if the patient want to get engaged in the sexual activities such as intercourse, they can do the injection. So that's what we do.
Great. Thank you very much.
Great. We have another question for Dr. Wang. Focusing on couples who really want to keep a good sexual life, our attendee asks, sexual rehabilitation starts already between the diagnosis and the actual surgery. So that should or could include improving the erection before operation, improving relational communication, erotic scenarios, and adapting the man or the couple to a wider range of sexual stimuli. What do you think about this? Do you consider that it is a realistic way to improve sexuality in these couples?
Yeah, it is a very wonderful, it's a great question, and that's coming up many, many times. And obviously in the ideal situation, if the patient and their partner are getting engaged before the surgical procedure, and to discuss the possible sexual side effect, and to discuss the possibility approach to take care of the problem. That is the ideal, probably the best approach. And also there's some studies show that if you have a supportive partner, patient has a much better recovery of their sexual function. Unfortunately, in the clinical practice, that is not feasible in many centers. Either in the busy center, you don't have a psychologist available, you don't have a sexual therapist, or you don't have a counselor, or if in the private practice, many people, they really do the things by themselves. They don't really have this kind of resources to do that. The ideal situation, absolutely, that's probably the best scenario, but it is not very practical in many places.
Thank you. And what about shockwave therapy? Is there any recommendation to use this before 5 years post-cancer? Because maybe guidelines have been changing about this. What do you think?
Yeah, there's always a concern, when this shockwave started, there's always a concern that the use of shockwave may cause the cancer either a spread or recurrence, and that was always a theory. Is in theory that can happen, but for now we have not found any evidence. And the two things we have not. Number one, we don't really know if shockwave is going to work for the rehabilitation. Number two, we have not found any evidence based on my knowledge that shockwave will increase the cancer spread or increase the recurrence of the prostate cancer. The key here is that really if shockwave is really working in the rehabilitation situation, or shockwave really works for the recovery of the erectile function after radical prostatectomy, that is still in question. We need a much bigger, larger multi-center study to answer that question.
Great, thanks. Now a question for Dr. Brock. What to do if hematocrit rises above 54%? Do you use testosterone decanoate if the patient is not comfortable using the gel in these cases?
Yeah, so I sort of touched on it, that erythrocytosis is a major concern with testosterone, and it needs to be monitored. The 54% hematocrit's a good number to look at. At that point, you certainly should do something. Either lower the dose, change the delivery system. So if you're using an injectable, probably switch it over to a transdermal or an oral, and ultimately look at a phlebotomy. So once they've reached 54%, I usually would go into action, and I typically would organize a phlebotomy that'll take care of the rise in red blood cell mass quite quickly, and then talk to them about dose and changing the formulation. And for most people, they typically, if they're on injectable, they like staying on injectable. So they'll go on to a fairly regular dose of phlebotomies once every 3 or 6 months.
Perfect, thanks. What about patients planning to conceive? Do you combine testosterone with HCG if they plan to conceive maybe in the long term, but not so very after the testosterone treatment? Or do you use a 6 months interval, then 6 months of HCG only? What is your practical experience?
Yeah, at least in Canada, HCG is a lot more expensive than testosterone. And so what we would typically do is not combine them, but instead offer them HCG if they are hypogonadal and they're thinking about conceiving, particularly if their FSH is low. We would move forward, or their LH is low as well. We would move forward with that if there's a problem with fertility and low testosterone with HCG primarily. But typically, I don't combine testosterone and HCG.
Okay. Another question about TRT. Can low testosterone be a result of a psychological cause? And if so, could such cases be treated with psychotherapy, counseling, CBT? How to ascertain if it is a psychological cause?
Yeah, no, I don't think so. Certainly in someone who's on medications, it can be medication related. And the only linked scenario to that I can envision would be someone potentially who's on opioids, maybe depressed, has some psychological issues, and then it would be the opioids. But I don't think a psychological issue really will dramatically impact on testosterone levels. There are other pathways you could hypothesize, perhaps if they are significantly mood depressed, and maybe Michal wants to talk about this, But if their sleep cycle was altered, that could affect their hormonal levels. But again, it's a stretch. And I think the real long answer I've just given is probably better off just a short answer saying it's very unlikely.
I completely agree. Do you want to comment on this, Michal? About women, maybe?
Well, it's from my clinical perspective, it's still difficult to talk about testosterone in females that because we don't have testosterone formulations for women to treat sexual dysfunction here registered, but and there are all the concerns about body image, consent, etc. But on the other hand, yes, testosterone is the fuel for sexual desire, and we might assume it will be. It might help a lot, especially in the menopausal stage. And the other thing is, referring to what Gerald has said, that yes, it's also whether it is an antidepressant. So in fact, in those individuals, so especially men who are hypogonadal, it might be related with unstable mood and also worse cognitive performance. And from my observation, giving testosterone to these men may be also helpful in these both domains.
Okay. For Dr. Brock again, do you monitor estradiol when on testosterone therapy for the purpose of prescribing aromatase inhibitors? And if so, do you use immunoassay or mass spectrometry to assess estradiol in men?
Well, I'm going to give my answer in a minute, but first I'd like to know your approach, Elisa. How do you monitor those guys? What do you do?
Well, we are lucky enough to have mass spectrometry in our hospital. So in those few cases that we want to check these levels, we try to do that because as we know, it's much more useful to use this kind of assay. But unfortunately, it is not so common to have this. So we have to keep in mind this kind of approach. And regarding aromatase inhibitors, let's say that if you see a man with a very high BMI, you can infer and suppose that his estradiol is high even if you do not check his levels. So our approach in our school is to maybe try this kind of treatment, explaining clearly to the patient that is off-label, especially in those who wants to conceive, and then if you want to try to rise the FSH levels, and so to have maybe a boost on spermatogenesis. These are the cases that we try to use that. So obese or overweight men, and when we are not convinced of use testosterone. What do you think?
So my answer was going to be almost exactly the same. As a routine, I don't measure it. Certainly in someone who's fat, where they have a large fat mass, that's when you're going to get high levels of aromatase. So that's the situation clinically where you'd want to consider using an aromatase inhibitor. So if you measure a hypogonadal man and you see that he's quite obese, then you can keep that in mind. But it is pretty unusual. And so as a routine, I don't.
Great. What about delayed ejaculation? What is your first treatment line? I mean, this is not exactly the topic of the presentation, but if you or Dr. Wang want to answer this.
Run, go ahead.
The delayed ejaculation is one of the most difficult clinical condition we are facing in sexual medicine. Number one, we don't really understand exactly what is the mechanism and why this happened to some people and why not happen to other people. And also sometimes it's situational, and the patient can do better in some kind of situation and sometimes do not. And we generally, what we do, we start with the carbagolines, whether that's going to help the patient. We check their testosterone, make sure their testosterone is in the normal range. And also sometimes we try to have some kind of behavior therapy, and we refer the patient to sexual counseling and to see if it will improve the patient's ejaculation experience. Unfortunately, many clinical situation, no matter what you do, the situation may not change very much. That is one of the challenges to us, and we really need a more scientific study regarding that. I do not know if Michal will have some input about this. Probably he can give you some suggestion or advice about that.
Oh, yes,
Gerald?
so yes, sure. If I may, so the most common clinical scenario with men with delayed ejaculation is actually that they can easily ejaculate during masturbation, and they have many issues with masturbating during sexual intercourse, and that has usually more psychological or behavioral implications. So in my expertise, I see very often that, of course, biopsychosocial approach is needed, but very commonly these guys need more psychological assessment, and they need more cognitive and behavioral approach.
Yeah, I would agree, with both Run and Michal, that it's typically the guy who comes and sees you and he complains about inability to have an orgasm and ejaculation, and he describes both with sexual intercourse. And when you ask him, it's really important to ask him, when you self-stimulate or masturbate, can you reach an orgasm and ejaculate? And sometimes they say yes, sometimes they say no. The guys that say, I can, then you measure testosterone and try and explain to them how they can change their sexual repertoire and maybe get closer to orgasm ejaculation when they're having penetrative intercourse. And oftentimes I explain that it's simply not that stimulating when you're having intravaginal penetration. When you're self-stimulating with your hand, you know where to squeeze, where to rub, and so you can really induce an ejaculation. There's the other group that's more challenging, where they grew up in a very religious household typically. So religious Jews or patients from the Indian subcontinent, very often they're looked at, masturbation is not right, and that ejaculation is a sin, and they've learned that behavior. And at that point, I think really psychosexual counseling is really the route to go.
Okay, I would go now on some question on women so that we can change the topic a little bit for Michal. What impact rape or threats of rape has on a woman's subsequent sexual function experience?
Well, really a lot. So first of all, the experience of rape or sexual assault of any sort of neglect had very often a lot of psychiatric sequelae. So it's related with further anxiety and mood disorder, and especially the PTSD, which is also very likely to be related. And it's very commonly under-recognized and not properly treated. So these women may have sexual complications even decades after being exposed to sexual trauma, also because of the so-called affective reminiscences from the time they were raped, for instance. So this is clearly an issue. So what in case of these women, they should have a thoughtful psychological and psychiatric assessment. And of course, very often when they need the treatment of PTSD, it's also commonly combined with pharmacotherapy. The most likely used drugs are SSRIs, which in fact are also responsible for sexual dysfunction. So they are very commonly related with desire or orgasmic disorder. So also keep that in mind. So we have to get a good interview of concomitant medication, which might affect sexual functioning in these women. And it also may affect strongly the dynamics of the relationship, and many reasons why people have sex in case when they had this sort of background of sexual trauma. So it's also good to see it from the relationship point of view as well.
And we have some data on sexual abuse, of course, but are you aware, you have been asked this, are you aware of any report on the negative effect of videos of one sexual activity recorded illegally as a way of a threat and harassment, or videos generated with artificial intelligence. I think this is very new, so maybe no one ever published on this.
Well, yes, we don't have resources on that. I haven't seen any convincing research on the use of AI in sexual harassment, or probably it may be used in two ways. So first, one might be, of course, the way of neglect, or to put someone into the perspective of sexual exploitation, or some artificial publications of someone having sex, but it was made by AI. And there is another perspective that is more therapeutic. How can we use AI therapeutically? But it's still to be developed. So we don't have completely no scientific data on that yet.
Thank you. For Dr. Brock and Dr. Wang, a very hot topic. What about TRT post prostate cancer?
Ron, why don't you start off and then I'll pitch in my few thoughts.
Actually, Dr. Brock has already discussed during his presentation. And if you ask this question about 15 years ago, and 90% urologists or even the physicians, let's put it this way, will say, no, patients with prostate cancer should not give testosterone. But we have a tremendous amount of evidence now these days that at least the evidence we have today, the patient has prostate cancer, especially has a treated prostate cancer, they give the TRT is pretty safe. Even the patient has a brachytherapy or radiation therapy, the PSA are stable, it's pretty safe to give them testosterone. And even more so that the patient has a active prostate cancer, they have this called a bimodal therapy. You give testosterone, you give androgen deprivation therapy. You do this like a cycle, and that will have no risk for the patient. Also, there's some benefit results as well. So clearly, the evidence are changing, and we will feel much more comfortable to give testosterone for patient that has prostate cancer or has history of the prostate cancer. Gerald.
Yeah, I would completely agree. I think the evidence is overwhelming now, but it's still something that when you're doing it, because patients and other physicians may hear about what you're doing and tell the patient something else, that I think you do need to spend a little more time with the patient and give them a bit of a historical information that's saying, 10 years ago, this was something that was contradicted. And in fact, on the label of the testosterone, you'll see they talk about prostate cancer. And so you need to understand, John, that this is something that is being used commonly around the world, but there's still some parts of the world and some individual clinicians that may tell you otherwise. But the evidence is really quite clear. We're going to follow you carefully. We're going to continue monitoring you. And if something changes, we'll act on it quickly. And I think with that extra piece of advice, the patient won't get in a situation where one doctor is telling him one thing and another doctor is telling him something that's totally opposite.
And what about sleep apnea? Do you consider it a contraindication? Do you prescribe testosterone in those with CPAP, BPAP?
Well, it's clear that there are, I do prescribe it, but it is a contraindication. And there are some very small studies, not very strong, that really do show exacerbation of sleep apnea with testosterone. So again, just like the testosterone with prostate cancer, it's something that really does need to be discussed. The patient needs to understand. And I think that that's something that needs to be monitored.
Great. Then we have another question for Michal. Can injuries to the internal os of the uterus during surgery or iatrogenic injuries impact negatively on the orgasmic experience of women?
Well, it's more a question to a surgeon, I believe, not a psychiatrist. If there is any sort of surgery, probably urologists know it much more about it than me. We all surround the genital area, and of course it may lead to nerve and vascular damage. So it's not very different from men actually, because they are the same structures that are responsible from the neurophysiological response in case of neurophysiological sexual response. So maybe you can have more better comments on surgery or
The
trauma.
problem that Ron and I both have, Michal, is that we never have complications. So we don't have any personal experience with this.
It's just the one comment, and that's what Jerry said was exactly true, because we don't have complication, and actually we don't do female surgery. That's what we don't know. But and then in our MD Anderson Cancer Center, what we are doing now for female patient, if they go through the radical cystectomy, and we also do the same approach as we do for male. We try to preserve the nerve, so hopefully that will at least elevate some of the potential physiological effect for the female sexual dysfunction. But it's a very complicated situation. You know that some people, they have their uterus removed. If you don't tell them, they may not even know about it, the difference. But if you tell them you got a uterus removed for any reason, or you have some kind of surgical procedure there, psychologically they feel they are different. So even that may cause some female sexual dysfunction.
Yes, that's a very good point, because of course there are studies showing that after certain surgeries of trauma, higher incidence of sexual dysfunction. But on the other hand, there are very often overlooked psychological effects. So even if you have this event as a surgery or trauma, it doesn't mean that the history behind, so the pathophysiology behind sexual dysfunction is not psychogenic. So good to know that.
We have a clinical case for all the speakers. Is Viagra or something similar, or testosterone, so a lot of treatment proposed, helpful for a young man with sudden zero erections following a coercive sexual relationship with a partner with likely bipolar disorder, including demanding sex? So he was traumatized, but refused to accept he was traumatized and refused psychological trauma treatment. What do you think?
Can you can you present it once more, because I didn't get all?
Yeah, sure. So we have a young man. The attendees that not specify if it is hypogonadal or no, with sudden zero erections following a coercive sexual relationship. So the female partner had behaviors like demanding sex. Probably she was bipolar. And so the guy was traumatized, but refused to undergo psychological trauma treatment. So in this case, it seems like a psychogenic, if you don't use this term anymore, psychogenic erectile dysfunction, may Viagra, sildenafil, or testosterone be useful?
Well, it's not a simple answer to that, yes or no. First of all, if you have this sudden incidence of erectile dysfunction, you have to consider two things. First one is that you have a sudden medical condition, which is probably not likely to be here the case. Or the other thing, it might be a sort of traumatizing or something has happened that very rapidly evolved this psychogenic cycle of sexual dysfunction. And of course, if a patient is refusing to take the psychological perspective, it's also very meaningful from my point of view. And whether you would use medication to such a patient, of course, to giving testosterone to someone who has no testosterone deficiency and this sort of the background of sexual dysfunction seems ridiculous. And what about PDE5 inhibitors? I very commonly see young men with psychogenic dysfunction, very often also with a rapid appearance, that are being treated even for long term with PDE5 inhibitors without any effect. So we have also always to weigh pros and cons for such intervention, because from one point of view, especially if you give a higher dose at the beginning of PDE5 inhibitor, it may affect a proper sexual response, and it may relieve the anxiety, of course. So maybe you can be successful that way. But on the other hand, if you start giving PDE5 inhibitors and it doesn't help, and very often these patients are taking one after another, so trying with higher dose, combining to PDE5 inhibitors, etc., and they start believing that nothing will help them. So they are looking for stronger and stronger medication, and this is really an issue in the office if you have such a patient. So always you have to follow the biopsychosocial approach, and of course you can use medication in such a patient, especially PDE5 inhibitor, but always beware of being too much medical in this patient, and always provide proper psychoeducation and psychological approach, even if a patient does not want to go deeply into that. But I always explain them the basics of this psychophysiological interaction, why their body might not work properly if there is an issue with high anxiety.
Do you agree, Dr. Brock, Dr. Wang? We have a couple of minutes for closing the answer.
So in this kind of clinical situation, that this diagnostic tools come up for play. In this kind of situation, patient refuse the psychological evaluation, and our job as urologists is that to make sure that patient do not have a physiological component involved. First of all, for sure, we want to make sure patient doesn't have any sudden change of the medical condition, cardiovascular condition, endocrine condition, and so forth. And then I will perform the penile Doppler study to make sure the physiology, the penile dynamic, hemodynamic is normal, and even if possible, and this is one of the situations I may perform a ridge scan. If it is normal and the penile Doppler is normal, that can come into the patient, explain to him that he does not have the physiological condition that needs to be treated at this point. And then I will try to convince the patient to see the sexual counseling, to see the psychologist.
Great.
I would do the same workup as run, but I think I would, in most cases, prescribe a PDE5 inhibitor. And I would tell them that likely the stress of the situation and the stress of your future erection encounters is causing a high sympathetic tone, and the Viagra or other PDE5 inhibitors may help compensate for a while. So that's the route I would take.
Thank you so much to our speakers and to all the attendees for this very engaging discussion. Thank you so much, and everyone had a great night. Bye-bye.
Thank you so
much,
very
Elisa.
much.
Thank
Great
you.
moderator.
It was a pleasure.
Thank you. Bye-bye.